So welcome to everybody. My name is Verena Menek. I'm the Vice President of CAG and a professor at the University of Manitoba, and I'll be moderating today's webinar. I hope all of you and all of your families are doing as well as you can during these crazy, difficult times. Let me start off by saying a few things. First of all, as some of you will know, that this CAG Webinar Series is a way to feature our the CAG Awards that we give out each year. So I would encourage everybody to take a look at the CAG website to check out the list of awards. We have many of them, and I do encourage you to nominate people for the awards. The deadline for applications is June 1. So that's coming up very, very quickly, but there's just time to get nominations in or make applications. You have just over a week to get that done. Secondly, just in terms of housekeeping issues, your microphones will be muted during the presentation. If you're on the phone, please mute your phone. That is to eliminate or reduce static or echoing. If you do have questions and comments, and we do hope for this webinar you do, please type them into the chat box on the right side. Well, at least on my monitor, it shows up on the right side of my monitor. If you do not see a chat box, please look at the top right of your screen, and there's a word bubble there, and click on it. That will open the chat box. So when you type in there your comment, it will show up for everybody to see. So please do use that. We will be saving those comments to after Dot and Kathy have talked, and then we'll take your and look at your comments. So I'm delighted to introduce the speakers of this webinar, Dr. Dorothy Pringle, who is a professor emeritus in nursing at the University of Toronto. She was the recipient of the CAG Distinguished Member Award in 2019. She will be co-presenting with Dr. Kathy McGilton, who is a senior scientist at the Toronto Rehabilitation Institute, and she's also an associate professor in nursing at the University of Toronto. So today's webinar tackles a difficult and very tragic issue of how long-term care institutions in some parts of Canada have been impacted by COVID-19. So while you're listening to Dot and Kathy talk, please think about what our responsibility is to fix the long-term care system. And by our responsibility, I mean all of us who are involved with older adults in one way or the other, but also what about CAG? What is CAG's responsibility as an organization? So what is our responsibility? What are our next steps? Please put your comments in the chat box. We really do want to hear from you. So let me turn the mic over to Dot and Kathy.
Thank you very much, Verena. And I want to welcome everybody. And thank you very much for joining us on this very important and tragic topic, unfortunately tragic topic. This topic was not my, there we go. This was not my first choice as a topic. I was going to talk about how to enhance the quality of daily life of people who live in nursing homes. But as we got closer to the date for the webinar, and Verena contacted me and said, "What's your title?" It was just about when things were breaking down in terms of the nursing home situation in Canada. And I thought, we can't do quality of life in daily life in nursing homes when people's job in nursing homes is to try and stay alive and survive the daily life. And I have always liked Winston Churchill's phrase, "Never let a good crisis go to waste." And I thought we could make use of this because we certainly had a crisis on our hands. And I thought it was a good challenge in terms of CAG as well. And as a long-term member of CAG, I'm thinking, what can CAG contribute to fixing this situation that we have? I'm very fortunate because I know a lot of people who know a lot about nursing homes, and I've drawn on their wisdom for this. First of all, I'm delighted that Kathy McGilton is joining me, and she's going to speak to particularly the issues of leadership in nursing homes. But I've also gotten help from Veronique Boskart, who's currently president of CAG, as at Conestoga College, Carol Esterbrooks, who leads the Translating Research into Elder Care program at the University of Alberta, Gail Donner, who's a long-term colleague of mine at the University of Toronto, and then I've used work that Drs. Pat Armstrong and Tamara Daly, who are both at York University, have done on the nursing home sector. I think I want to say, first of all, that we're going to talk about a lot of terrible things about what's going on in nursing homes, but I want to make it very clear that there are many excellent nursing homes in Canada taking very good care of the people who live there, and those people have enriched lives in the nursing homes. But unfortunately, there are a lot of nursing homes that are not living up to the expectations that we have for them. Now, some of the excellent nursing homes have gotten into difficulty, and many of the not very good ones have as well. But we're not talking about all the nursing homes in Canada in terms of the tragedies that are happening. I think I'm pleased that Verena encouraged everybody to make contributions in terms of comments and questions as we go along, and certainly at the time we've set aside at the end. Yeah, here we go. We've got some objectives. One is, first of all, to acknowledge the crisis in the residential long-term care sector in Canada, and then provide a brief and quite high-level overview of the long-term care system in Canada. We would talk about the types, the leadership, staffing, etc. And then about the fundamental issues that are plaguing this sector, and trying to understand why that we've known about these issues for literally decades, and why haven't we, or why hasn't something been done about them? And then really be able to exchange, to the extent that we're able, what we might do about them, where we would start, and then what CAG's contribution would be. All right, the ingredients of the I think we could start with the pre-existing fragile state of nursing homes, and it involves all aspects of nursing homes. The residents are fragile, the staffing is fragile, and for many of them, the physical plant is fragile. And then we get the introduction of this very infective virus, COVID-19, to the world. International travelers, unknowingly for the most part, unknowingly, I think, for all of them, introduced COVID-19 to Canada. Some of them visited nursing homes, and some of the employees of nursing homes were exposed to COVID-19 and introduced it to the nursing homes. The PPE was not stored in a lot of nursing homes, was not made available to the nursing homes. Even if some nursing homes had PPE, they did not make it available to the employees. And if many employees, if they did have access to PPE, had no training in how to use it. And this led to vulnerable residents and nursing home staff becoming infected. Infected staff stayed home and others stayed home, mostly to avoid infecting their families or because PPE was not available to them. Residents became infected and some were neglected. They were dehydrated. They did not receive any food. They had no personal hygiene. This led to 82%, it depends on the day, 82% of deaths in Canada from this virus are residents of nursing homes. And 1,400 soldiers are in Quebec caring for residents in nursing homes. More than 400 soldiers are in Ontario nursing homes. And Prime Minister Trudeau says we should not have soldiers caring for Canadians who live in nursing homes. And I quite agree with him. Okay, now we're stuck. Okay, there we go. It's hard to do a pan-Canadian description of nursing homes because each province regulates their own nursing homes. They're called different things in different provinces. I'm going to call them nursing homes because 5 of the provinces call them nursing homes, but they're personal care homes in Manitoba. They're called long-term care homes in Alberta. They're called special care homes in Saskatchewan. And in Quebec, they're called centres d'hébergement de soins de longue durée, generally called CHS. And in Canada, nursing homes are defined as providing 24-hour, 7-day-a-week provision of accommodation, food, laundry, supervised care, professional health services, now pay attention to that one, and personal care. The nursing homes are not included under the Canada Health Act. It's only hospitals and doctors that are included. So the 5 principles under the Canada Health Act, and that's public administration, accessible, comprehensive, universal, and portable, those principles do not apply to nursing homes in Canada. So there are no national standards or regulations that nursing homes have been required to meet, and provinces each set their own regulations and standards, but the surveillance and enforcement of those standards varies very much across the provinces. Okay. There are usually 3 types of nursing homes in provinces. You don't know walking by them which type they are, but it's about the funding. 50%, about 50% of the nursing homes in Canada are private for-profit. Many of these are parts of chains such as Extended Care, Chartwell, Sierra, for example. About 30% of them are either private or charitable, not-for-profit homes. For example, a lot of the cultural groups in Toronto, there are a couple of Chinese nursing homes. There's a Ukrainian nursing home. Some of the religious groups have nursing homes. And then there are about 20% that are run by municipalities generally, and they're not for profit. And I'm in Ontario, and this is fairly typical across the province, except for Quebec, and I'll talk a little bit about that. Ontario provides to each nursing home a basic per diem for each of their residents for all types that will cover 4 what are called envelopes of care: nursing and personal care, programs and support services, food, and other accommodation. And residents pay an amount for room and board. In Ontario, that is set at a maximum of about $1,900 a month. But it may be as low as their what that person receives in terms of pensions, the maximum of pension support in Canada. Residents may pay a top-up to get private accommodation or larger private rooms and to get more services. But in the private homes, in the private for-profit homes, a lot of services will be provided. Having your hair dressed, maybe additional laundry services, maybe some additional health services such as a physio coming in, etc. These folks pay for those on top of what they're paying to the organization. Almost all homes across, or all provinces require that about 40% of all nursing home beds be available at the basic rate. Now in Quebec, they have 3 types of funding for their nursing home, and that's really should be types of funding as opposed to types of nursing homes. They have a private for-profit that does not receive any provincial funding, but nevertheless, they are considered part of the nursing home system in Quebec, and they are usually counted into the number of nursing homes that are in Quebec. So just to give you a sense of what a big sector this is, much bigger than the acute care hospital sector. There, I think, it's hard to get a handle on it, but I think there are about 1,500 nursing homes in provinces and territories outside of Quebec, and about 500, maybe 519 nursing homes in Quebec. And I think that includes that for-profit private sector. For example, Ontario has 627 homes, PEI has 19, and the Yukon has 5. So we have a lot of nursing homes some places and very few in others. And approximately 5% of Canadian seniors live in nursing homes. 80% of those are over 80, and most people entering nursing homes now, not all, but most, have some degree of cognitive impairment. That's hugely different than what the circumstances were back in the 60s and 70s, 1960s and 70s, when nursing homes began to be developed. But we're going to talk a bit about that later. We don't know how many healthcare aides there are. We know the number of registered nurses and registered practical nurses there are in nursing homes. There are very few registered nurses, and that number is dropping all the time. There are, with more practical nurses, that number increasing. But we don't have a registry of personal support workers or healthcare aides. We know there's somewhere between 250 and 500,000 healthcare aides, and there's about a 33% turnover of healthcare aides in nursing homes every year. For the staffing in nursing homes, well, you've got, every nursing home has people who manage the food services, a dietitian and the food preparation folks, the janitorial and housekeeping staff. There are both of these groups, the food services and the housekeeping, are very important in the lives of people who live in nursing homes. They're the administrative staff. The larger homes will have folks, recreational staff, rehabilitation staff, and social work. For healthcare, there are usually 3 levels or 3 groups of staff. Registered nurses, and these in Canada now, that usually somebody with a baccalaureate degree in nursing. Registered or licensed practical nurses. These folks have a 2-year college program. And then healthcare aides, who are also called personal support workers, who are also called nurses aides, or continuing care assistants. The certified ones are usually products of a community college program that's 2 years in length, 2 terms in length, sorry. I forgot to add in that there are some nurse practitioners as well now in nursing home. And there are in 45 nursing homes in Ontario, there's a nurse practitioner who is based in that nursing home. I think there's funding for 90, but they frankly cannot fill the other positions. There's been a lot of research done both on this project in Ontario and in nursing homes in the United States, because quite a number of theirs have nurse practitioners. And they have demonstrated that with a nurse practitioner on site, there's significant reductions in emergency room visits, admissions to acute care hospitals, and families have significantly higher satisfaction with the quality of health care provided to their relatives and to the quality of life that the resident has. There are other important people who provide a lot of assistance in nursing homes. They're not paid. These are the family members of residents of nursing homes. Provide social care. They may assist with meals and toileting, but they play a big role in the quality of daily life of people who live in nursing homes. They help to keep residents mobile because they take the time to walk, take them out for walks, etc., and for a lot of comfort. There's some folks who will have paid companions, families providing the companions, and they may provide some personal care, but it's largely around companionship that they're hired. Now, healthcare aides, they're such an important component. 90% of these people are middle-aged or older women. When we're talking about nursing home, we're talking about a very gendered sector. The majority of residents are women. The majority of people who look after them are women. 50% of the healthcare aides speak English as a second language. It's a higher proportion in cities across Canada and a lower proportion in rural areas or small towns. Wages usually range from about $13 to $25 an hour. The $25 an hour folks are the ones who are unionized. There are many more unionized healthcare aides in Canada than the US. But a lot of the homes control their costs by not making full-time jobs available at this $25 an hour. So if you work part-time, then you don't have sick days, you don't have benefits, sick days or vacation time. And so if you're only working 3 days a week, then you may have to work in another nursing home or a couple of other nursing homes in order to get a full-time salary, but you still are not getting any benefits. 25 to 30% of healthcare aides work in more than one facility. And then there are agencies who hire out healthcare aides to nursing homes. And these agency staff may work in several nursing homes. And some nursing homes work with agencies, so all of their staffing is provided by those agency staff. Carol Esterbrook's group did a study a few years ago on healthcare aides in nursing homes across the West. 50% of the healthcare aides said they were not able to complete one important or necessary task for each resident each day because they simply did not have the time. That's long before COVID showed up. Most healthcare aides don't have access to continuing education. And I think they are subject, at least in some places, to ageism by association. We know there's ageism in this society. There's certainly ageism in terms of the people who live in nursing homes. And I think people who look after people who live in nursing homes may catch ageism by by virtue of their job. Now, the residents of nursing homes. When nursing homes started to be created, these are nursing homes that are funded by government. There are always little nursing homes where people who were ill and families couldn't look after them any longer, and they went to these small homes and women looked after them. They may have been retired nurses, sometimes set up their own nursing homes. But when the more formal nursing home sector began to get going in the 60s and 70s, most people who entered them were mobile. The residents themselves were in their 60s and 70s. And there were not this overwhelming proportion of people with dementia. In fact, we didn't talk about dementia. Everybody was senile in those days. In 2020, the average age is 85. 80% have some degree of cognitive impairment, and all have poorly functioning immune systems. 70% are in wheelchairs. They have chronic illnesses like diabetes or kidney, lung, heart disease. Even if the residents are independent in terms of bathing and mobility when they enter, they're going to progress to require bathing, feeding, toileting, transferring, and they require expert and loving care. The goals of nursing homes should be, and for many are, to provide a warm and caring environment to sustain residents till they have a good death. But the situation in nursing homes now, and these are the good ones as well as the not good ones, are we have frightened people confined to their rooms, isolated in their rooms, who don't recognize the people who come in to care for them because they're wearing PPE. And if these residents have dementia, they may be used to, they may spend their days walking the halls of the residents. And meanwhile, we're requiring them or trying to keep them confined to the room for infection control purposes. But it's a very unhappy, and families are not allowed to visit. So it's a terrible environment now. Status of COVID-19. Now this has changed as we speak. Since we started this, these numbers have changed. We have over 80,000 people infected in Canada now. Late last night, it was 80,142. We're getting close to 41,000 now who have recovered. 6,031 people had died. 82% of the deaths occurred in nursing homes. That is the highest percentage of deaths in the world. That is not anything for Canada to be proud of. In Ontario, 3 PSWs and 1 registered nurse who worked in nursing homes had died, but a 4th PSW who worked in a nursing home in Ottawa died yesterday. So we're losing people to this disease. Okay, Kathy, can I ask you to talk about leadership?
Absolutely.
Can we get that?
Thanks,
Hold
John.
up. There we go.
There are multiple leaders in nursing homes. I have just outlined, obviously, administrators. The next is the director of care, who's often the registered nurse, the charge nurse supervisor, who's often the registered practical nurse or the registered nurse, and then the healthcare aide, because we see leaders in healthcare aide as well. Some of the issues, what's really important to realize is that those in leadership positions guide both clinical and operational aspects of the facility. So for a long-term care facility to provide effective living situations for residents and effective working conditions for staff, layers of leadership best operate when they're aligned in terms of policy, vision, philosophy, and expectations. But however, because of limited knowledge of effective leadership and management strategies for improving nursing home quality of care, there are sometimes issues in terms of how leaders are enacting their roles. Some of the major issues we have seen is a huge amount of turnover at the director of care level in some of the research we've conducted. So what's happening here? We also see issues with recruitment and retention of the charge nurse and supervisor. In particular, we have a very hard time attracting RNs, just like nurse practitioners in nursing homes. Why is that? For those in leadership positions as well, there's little training, despite Institute of Medicine reporting that probably the quality of nursing homes can actually be modified by effective nursing management and leadership. It's a central factor to ensuring quality of care. So despite having numerous studies that leadership matters, we have continued to see a widespread failure to recognize and do anything about this. And so I just want to let you know, these are some of the current issues, Dot, that we have to grapple with moving forward.
Okay. Well, without much difficulty, we were able to come up with what we think are 15 fundamental issues involved. We do not believe that this is a exhaustive list, but it is nevertheless, and it's not a new list. These issues have existed for a long time now in nursing homes. I think that the top one is nursing homes are supposed to provide high quality care and good quality of life. It's the resident's home. It should be comfortable, safe, stimulating. There should be sources of pleasure for the resident. They should be well fed. And unfortunately, that's not happening in too many nursing homes. The funding of long-term care is, it's bare bones. The Toronto Star did a terrific, I think, expose, or first of all, explanation and then expose of the funding situation. Now, it was on Ontario, but you could transfer that to most provinces around how the municipal and the private not-for-profit homes put money into, they raise money, tax money for the municipal homes and donations, public donations into the private not-for-profit homes, and how the for-profits tend to take money out of the homes. Again, there's some excellent for-profits. I don't want to paint everybody with a black brush, but the funding situation and the provinces are simply not putting enough money into it. Is there a role for the federal government here? That's a question. There are too few nursing homes for the demand on them. That causes the ALC, alternate level of care, people in acute care hospitals, and it also means that there are long waiting lists. Nursing homes that have a very good reputation have long waiting lists to get into them. We don't know, we have made the decision so far that the federal government does not have a role to play. The question is, should there be a role? Should there be national standards? Our information systems, the data that we have about nursing homes is terrible, it's lousy. 5 of the provinces have the Inter-I system, but to be able to use Inter-I, yeah, I think you better have a master's degree at least. It provides good information, but it requires a lot of interpretation. And we just don't have basic information about this sector. Many of the physical plants are old. They were built in the 60s, 70s, 80s. There's still too many of them with 4 bedrooms or 2 bedrooms. The rooms are small in these homes. They share bathrooms. It's not good when there is a flu outbreak, or the situation we have now. Regulation. Well, I'm going to quote my colleague Gail Donner, who says, "We over-regulate the useless and we don't regulate the useful." Do we have standards for the right things? It's like regulation. We regulate what's in the standards, but are there standards for the right things? As Kathy said, staffing and leadership is really the backbone of the long-term care sector, and it's bare bone at the best of times. And we have no capacity currently in our nursing homes to manage crises that occur. And it's not just the COVID. This is true if a number of the staff become ill, or if there is a flu outbreak, etc. We just don't have any cushion there at all. We underutilize the capacity of the healthcare aides, the personal support workers, as they're called in Ontario. Nobody asks them their opinions. They're the ones who know the residents best. Again, Carol Esterbrook's group has done some terrific work, that SCOPE project, where the healthcare aides form teams and really were the managers of the care with the resources. Resource to them were the charge nurses and other folks in the nursing home who could bring evidence-based resources to them. The remuneration and the full-time, part-time problem of the hiring position. The remuneration is less of a problem for the unionized staff than the fact that there simply are not sufficient full-time jobs. Leadership is an issue. It's just an issue. We have an isolated system. It's not integrated with the acute care system, with the home care system, with public health. And the situation we have now really demonstrates the difficulty when we don't have integration across these sectors. The role of the family. We really haven't, we have family councils in most homes. I think all homes have to have a family council. But now with this outbreak, families are excluded, people are dying alone, and that can't be allowed to go on. That's simply ridiculous, where we're letting a regulation get in the way of the kind of care and the well-being of both the family and the resident. And then we have the problem of the regard, the status, the valuing of old people and where they live. Our federal minister of health has said we don't value people who look after other people. I think that is absolutely operating here. So why have we let these, got the wrong way. Why have we let this go on for so long? Well, because we don't value the work of looking after other people. And this is well beyond the nursing home sector. We don't value childcare workers or shelter workers. To a lesser extent, social workers and nurses as well. And if you don't value something, you don't protect it, you don't take care of it. There's stigma and invisibility associated with being old and demented. And again, low priority goes with those statuses. And unless a resident is your mother, father, sister, spouse, she's kind of invisible to larger society. And the nursing home sector have been easy targets when budgets have to be cut, and there's no powerful lobby groups to protect them. And this certainly happened in Ontario earlier in this government's tenure. Maybe has turned around a little now. But in any case, that brings us to how are we not going to waste this good crisis? And where do we start to fix this? So I'm going to ask Kathy, or I think Verena, this is where you're going to help us out in terms of some of the questions or comments that are being made.
So I would like to start because I have been writing a few notes down, Verena, and you can add. One of them was around, there are actually other leaders in the organization, for instance, recreational therapists, social workers, spiritual teams, and absolutely. And in fact, that was the purpose of having today's call. We want to make sure that stakeholders are represented beyond nursing. I don't know if you noticed, but Dot and I are nurses. We do have a bit of that behind us, and yeah, maybe. And so it is important. This is why we wanted this call, because we want to make sure that all stakeholders are actually part of the solution. And I think in terms of being devalued, I think working in these positions, we have had some comments that we're having a difficult time finding physiotherapists to work in nursing homes, recreational therapists. Absolutely. Thank you for keeping that as, you know, that's normal for, yeah, all professions. I don't.
Yeah, and I agree. And I think, frankly, we need all these professions contributing. Because the complexity of the people who live in long-term care now requires the expertise of all these disciplines. And all these disciplines are having the same problem in terms of recruiting nurse practitioners, registered nurses, and the other health professions.
Another question that was asked was, do you have a perspective on civil rights and human rights in nursing homes?
I have a perspective on it. I think we're in big trouble in terms of this. I think, frankly, this situation with COVID-19 has surfaced the problems around, is it really legal? Is it really, is it legal? But even if it's, why are we keeping families out? Can families really be kept out of nursing homes? I don't know the answers to that question, but I think we really need to look deeply into what where we're protecting the civil rights of the residents and the families and the workers in long-term care.
Kathy, can I interject?
Of course.
Can I just ask Dot, there was a question around a public inquiry. What do you think about a public inquiry, and is that on your wish list? So CAG, as a premier organization of issues of aging in Canada, what role is it for CAG to push for a public inquiry?
Well, I hope CAG does not push for a public inquiry. We've had so many public inquiries. Gail Donner chaired a public commission in Ontario half a dozen years ago on nursing homes. Other provinces have had inquiries into nursing homes. Actually, we know what's wrong. I've got a stack of newspaper. I've been ripping things out of the newspapers ever since COVID hit us, and they detail, frankly, all the issues in the nursing homes. We need to have an action committee to start working on these. I think it's everything, all these 15 items that we listed here need something done about them. Some of them are huge, some of them aren't huge. I think when we say, where do you start? I think that's an important question. Where should we start? And we should start now to start fixing this. A public inquiry, well, if we need public inquiry, let's just dig out all the ones and have somebody go through them, all the reports, and do an analysis of what has been identified, because nothing has been done to improve things since, these previous public inquiries. So I sure hope CAG is not going to ask for a public inquiry.
Thanks a lot for the thought. Kathy, I'll turn it back to you.
Clear.
Yeah.
Maybe I wasn't clear on my position.
No, it's quite clear. Another question that was asked was around decisions made during the pandemic. And in fact, someone was referring to the Globe and Mail, I think this morning, where we transferred clients living in transitional care programs and from acute care hospitals, and they brought them into nursing homes because they wanted to make sure there was enough beds in the acute care. And that was an interesting question. And I guess we think about how do we prepare for the next pandemic? Is this what our role is, to kind of come up with who made decisions to bring the Army in, who made them, why did they make them? We have now, the new thing in the Globe and Mail is we're going to ask anyone that wants to come work in a nursing home, and we're going to provide some training. Who's providing that training? What does that training it consist of? Like, so I think that is what I'm a little bit concerned about. And should we be able to create a better plan moving forward if this happens and when this happens again?
Well, if we've got over 1,800 soldiers in nursing homes, I sure hope war does not break out anywhere that requires us to fight in it, because they got to have a fairly big proportion of it. It's not okay to have to call in the Army. It was the Premier of Quebec who called in the Army, and I don't know who told him to do that. I think we have to get through this crisis. I think if it means recruiting students or whoever, and people who maybe have a previous background in a health discipline to go in and have some training, and training not only in the hands-on things, but training on how you work with older people, how you work with people who have cognitive impairment. This is skilled work. And I worry that a 6-week training program, or it's not even 6 weeks, I think it's a couple of weeks, training program is just scratching the surface in terms of how we do this. But we got to do what we got to do to get through this crisis and reduce the people who are dying in nursing homes, and make sure that people are getting fed and getting bathed. But then this is where I think we look at what previous investigations into nursing homes have indicated needs to be changed, and make some national decisions, because it's a national problem.
Back to the question also around human rights. I just want to, I'll probably post this later. Andrea Iboni has come up with this dementia toolkit. It's actually to support decision-making and in developing infection control and isolation care plans for residents of long-term care, taking into account principles of human rights. It's actually really well done. And so I'm going to post that, because I think that's actually critical that we're thinking about this.
Okay, good.
Arena, do you have any other questions?
Well, in terms of the, Kathleen Edwards just made the comment around that to start off with what is practical. And that's, of course, like Dot, you mentioned, there's some issues are so big and complicated. So what would you say would be the most practical starting point? And again, with an eye on what is it that we can do, we as a collective, we as an organization, we as working with other organizations to tackle these, all your excellent points. Where do we start?
I think I'd like to start with what are residents' actual needs today. I think Dot walked us through a beautiful kind of trajectory of where our clients were when we created nursing homes in the 60s and the 70s, and what they are like today. The increased complexity, multiple comorbidities, persons with dementia, the families that are also a bit older that are coming in and in the nursing homes with us. I think we forgot that they actually need many different issues need to be taken into account: emotional care, social care, health care. How do we prevent decline? So maybe looking at what are their actual needs, and then who's best to help meet those needs. And I think that would be one place to start, and trying to talk about a place where we try to maintain some of their abilities instead of not having the correct staff to help prevent decline. Dot, what are your thoughts?
Well, I think we have to have people here. So many of things that need to be fixed require well-trained individuals who have expertise in aging, in healthcare, in relationships, and I think leadership from that. And I think I think that to really make these places homes. Now, I would say we need leadership, absolutely. And I think there are good leaders in organizations that it's really come out of long-term care. They haven't been able. They haven't had as much influence as they deserve, frankly. But we need a lot more of them, and I think we need a lot more leadership from all of the relevant disciplines in terms of contributions. And I guess maybe in nursing homes, probably more than any other sector of healthcare, calls for teamwork. You know, that everybody, we have too few. I'm glad that somebody from recreation or rehabilitation has contributed, because we far too few of, I'm sorry, I hate the term allied health. We're all allied health. But we need a lot more contributions from those sectors in terms of bringing more creativity to the daily lives of people in nursing homes. So there's no magic bullet. There is no magic bullet, but I think we have to have, I think we have to find a way of overcoming this reluctance of people from all the disciplines to come into the aging field. We don't have enough. We don't have enough experts from all of these. We've got excellent experts, but we don't have enough of them.
Yeah.
And
I think we can't underemphasize the importance of the strong leadership skills, because I think at the end of the day, you're right, residents want to experience human connectedness. And so you need leaders to focus on that as an energy, as focus as well. And what does that look like? And I think we had another comment around care homes, social care. Should we be calling them more what the UK calls their homes? And you know, that is a possibility. I think they also struggle with that, because then you're right, in the end, they actually have less interprofessional staff in some of them, because they're saying it's just fair, it's just social. And I'm not sure they're actually pleased with that either. Some of the researchers I am talking to and administrators in the UK, because these clients need more than social care.
Yeah.
Some of them. Yeah.
Yeah. I think more. Well, we need. I think the naming is an important factor, because I think nursing homes have taken on they have to overcome that. When I say overcome that, there's a sense of well, I don't think it conveys the potential of nursing homes. And a lot of nursing homes don't call themselves nursing homes. They have other names. So we call the sector, well, long-term residential care, I think, is a better name. And maybe just drop calling them nursing homes. I think it's not as big an issue as having far more people, skilled, expert, across the sector from all of the disciplines, and far more leaders who can move forward and begin to solve all these other kinds of issues. They also need more money. I'm sorry, the funding isn't high enough. You know, we've got to get more dollars into the nursing home sector, into the residential long-term care sector. And that brings us to taxes, maybe insurance. Somebody I think it was the Globe and Mail this morning, said, we need an inheritance tax. Well, if that went into the sector, I'd be in favor of it. It's not going to affect me a whole lot, but we need more people, more money, more leadership, and maybe more time. No, just about.
I want to just, thanks, Dot. The question, there's a few comments, and the chat box, if you've been following it, it's just filling up so quickly. It's hard to keep track right now, but I don't want to lose sight of the issue around who is involved in decisions, both within, if I understand the comments correctly, so within a long-term care sector, so that we don't lose the voice of residents, we don't lose the voices of families, but also outside. So who can advocate? Who are those whose voices are heard in that sector, and how can we make people heard? And that, I want to tie this back into what you mentioned, Dot, about that there's no lobbying. There's no lobby group. We don't have a lobby group for, you know, cancer has lobby groups, but we don't have them for long-term care. Could that help to have people's voices heard, and all the voices, not just healthcare, not just the governments, but actually residents and older adults and us who may need long-term care in the future? What are your thoughts?
Well, I think so. Now, I think that Alzheimer's Society has done a terrific job and has an effective lobby, and is a friend of the nursing home sector, the long-term care sector. But I think it is important, but I think in so many ways the long-term care sector is so big, but on the other hand, kind of amorphous. And so I think we probably need to take leadership from the organizations that we have now, but find ways of making them more effective. I think where we have to bring the families into these organizations. I think of the long-term care organizations. Most of them, there's a long-term care association in each province. Some of them tied to the home, sometimes broader than that. But it's a place to start. And I think I think CAG, working with them. I'm sorry, I'm laughing. I'm just yelling at my husband to stop making a noise. But it's, you know, we're working from home. We're all working from home these days. But I think it's maybe starting by really looking at who have we got across the whole long-term care sector and the aging, because I think we need to bring the expertise from the folks who identify with the aging group as opposed to a sector of the healthcare system. But we need that expertise to know what the healthcare sector should be providing. And it absolutely has to be interdisciplinary. And I think that this is where I think CAG maybe can play a leadership role in mobilizing the organizations to work together and to identify some of these issues to take on.
Thanks, Dot, for this. And none of these questions and issues are easy, and there are no easy solutions, of course. We are at the hour where, according to my clock, at 12:01, we're going to be probably losing our webinar line fairly soon. So, Dot, Kathy, one final comment from you. Sorry about all the people we did not get to in the comment section. I hope everybody had a chance to at least read the comments. There's some excellent comments.
Okay.
Dot, Kathy, any final words?
Yeah, my final thought is a reckoning of how we treat staff working in nursing homes is required.
Yeah.
Mm-hmm.
Well, I see a couple of comments from Gloria Gutman, and I'm going to respond to those. And one is, Gloria has pointed out that many nursing homes, in fact, the majority of nursing homes in Canada have not had an infection of the COVID-19 virus. Because I worried as I was putting this together that because there's so much negative material in the press these days, that we think the whole sector is in trouble. The whole sector is not in trouble, except the whole sector suffers from, I think, problems with leadership, inadequate funding, underutilization, most of them underutilization of the healthcare aides, and lack of data to be able to use to understand what works, what doesn't work, and what needs to be done. So I think that would be my final comment.
Thanks so much for that. Again, there's a few more comments that have come in. Just take a moment. Oh, they're still coming in fast. So clearly this is a hot issue. As an organization, we'll definitely, discuss it and see how we can proceed. And I've taken notes. We have notes on your comments. The webinar, as was pointed out initially, will be posted on the CAG website. So you can re-listen, or you can mention to people who were not able to get on that it is there to listen to. And thanks so much again for everybody in attendance, for your comments, for your contributions, and especially Dot and Kathy for your very excellent presentation.
Well, thank you very much. Thank you for this opportunity. Terrific.
Thank you. Have a good day, everyone.
Bye-bye.